बिस्मिल्लाहि मिनश्शैतानिर्रजीम बिस्मिल्लाहिर्रहमानिर्रहीम. Now we are coming, we actually reached up till the session which I am going to discuss, the last session, not the least, and that is, it is the session number 9. I am talking about the session 9 of the clinical chest radiology plane, the plane X-ray radiology. And the topic of today is ATELACTASIS, actually, which is a difficult topic to discuss as far as the students are concerned. As postgraduates, not a problem. It means that it is a collapse of the lung volume. There is parenchyma and the supply is to the bronchi, and alveolar spaces are and the alveolar membranes are the ultimate source of oxygenation here. So it is collapse because of the lung volume, that is the parenchymatic spaces, or you can say the alveolar spaces. They leaked out all of the air from the alveoli, or they are now in collapsed state, or you can say they approximate each other. It may involve the entire lung, it may involve the lobes, it may involve the lobules, or a segment, it may be subsegmental. Very small portion it is. It is hardly 10 to 20% of the lung volume is concerned. First of all, remember the terminology. ATELACTASIS, collapse. Now there are some direct signs of ATELACTASIS, like displacement of the fissures. On the right side, this is the fissure which is called oblique fissures and transfer fissure superiorly. And on the left side there is one fissure only, and that is the oblique fissure. If it is seen in the normal X-ray, if you can detect it, then it is the displacement of the fissures. Second, in the first fissure, which is the transfer fissure, is parallel to the second intercostal cartilage, very near to it. And the oblique fissure is actually from the back to the front. It is coming in the 4th or 5th intercostal space. So it is coming from the 4th rib, and obliquely it is going to the 5th rib. It means that it is 4th or the 5th intercostal space. And the same on the left side is oblique fissure, same position. That is, it is starting from the 4th rib and ending obliquely to the 5th rib. That is 4th intercostal space or 5th intercostal space. If they are displaced upper or the lower side, whatever it is, this is the direct sign. Second one is the increase of pacification, because air is gone, aerogram is gone. So what is remaining in this segment or in the lung is only blood supply, broncho-vascular markings are seen, and crowded aerobronchogram, because they are very crowded now. It is non-obstructive in variety of the ATELACTASIS or vessels. They approximate each other. These are the direct signs of the ATELACTASIS. Wherever it is found, where it is, you will detect it, and accordingly the result will be obtained. Indirect sign in X-ray are the displacement of the hilar structure, ipsilateral cardiomyocytal shift, and narrowing of the ipsilateral intercostal spaces. They are narrowed. Obscured structures adjacent to the ATELACTASIS, obscured. Structures, ATELACTASIS very near to it, they are obscured. Haziness is there. Elevation of the ipsilateral diaphragmatic leaflet, it may be elevated, it may be depressed. In case here it is elevated, and because the lung volume is gone, just superior to the diaphragmatic or the what is called as the right hemidiaphragm or the left hemidiaphragm. Hyperexpansion or hypertoslency of the remaining aerated around compensating emphysema, that is hyperexpansion, hyperlucency we call in our language, to the remaining part or adjacent to this. These are the indirect signs. Now, hazy opacity in the left upper lung, this one, look this one. And trachea is shifted to the same side. It is indirect sign, this is the direct sign. Indirect and loss of the left cardiac salute sign. Salute sign means that obscured margin of the mediastinum, middle mediastinum. It is obscuring here. It is called Selhort sign. Selhort sign, if it is present, it means that most often it is the involvement of the parenchyma actually of the lung, which causes the obscuration of the border. According to this, there is left cardiac salute, the indirect sign, Selhort sign. Now, lobar collapse concerns anatomy is right upper lobe and right middle lobe and left lower lobe. Approximate positions are given here. This is the surface anatomy. The right lobar anatomy is seen here. This is the manual fissure, transverse fissure. First rib, second rib below that. The lateral side, lateral view it is. This is oblique fissure very clearly seen from the fourth, rib or fifth thoracic spine, down going like this towards the anterior mediastinum. This is the position. Now it is gone, then it will come. So for example, this part is gone, then it will move up. For example, this is gone, this will go up, diaphragm up, and the fissure is displaced, downgoing. It is down. It is indirect sign. The middle lobe is concerned, again here on this side, the middle lobe and the lower lobe, indirect sign is that this fissure, if it is displaced, so it means that the thing is this, middle lobe is displaced there. The direct sign may be there or indirect sign may be there. It moves downwards or it moves upwards, depending upon which part is gone. Now, left lobar anatomy is left upper lung and the left lower lung. Now, this is the position of the anatomy here, and this is the fissure. It depends upon the fissure which is lying there. Lobar anatomy here, the left upper lung, it is a major fissure which is there, not minor fissure. Its direction is towards second, and then in the middle line it is fourth, and then it is sixth. It is the line actually which you should detect on the lateral views. The right upper lobe ATELACTASIS findings include the elevation of the right hilum and the minor fissure, of course, and a collapsed lobe shifts cephally and medially. Collapsed lobe will go up, definitely. It is if due to the central mass, the minor fissure retracts cranially with a lateral upward convexity and a medial caudal convexity, as sign of Golden, this is called. This suggests the new plastic etiology. It is difficult to understand. When you see the X-ray, you can find it. So it is the obstructive nature of the ATELACTASIS or the displaced nature of the of the collapse. There are two possibilities: whether the bronchus is obstructed or some mass is displacing it. The right upper lobe ATELACTASIS, the ATELACTASIS right upper lobe forms a triangular opacity. This one, the elevated minor fissure is retracted cranially. This is the minor fissure, displaced cranially, and is retracted cranially and forms the reverse S sign of, this is the S sign. This one has, this is the reverse. This is the part 1, this is the S. As it curves around the hilar mass, this is the mass, and because it pushes this one, there is a collapse because of the obstruction there. It is S sign. You can remember, okay, you cannot remember, that's fine. Right middle lobe atelectasis, again the same thing will happen. That is the right middle lobe, only 10%, and it is a difficult one. Although today the CT is the main tool of the diagnosis. There is a small triangular opacity pointing laterally, obscured right heart border, that is Selert sign. And the lateral view obliquely oriented triangular opacity is the apex pointed towards the hilum. Now this is one. Right middle lobe atelectasis. This is what I have told you just now. Displacement of the transfer feature is there. It's moved up. The minor feature will go up. The lateral view, it is very clearly seen here. And see, there is a atelectated middle lobe opacity between the fissures, two fissures. This is or triangular opacity. It may be differential diagnosis of anything. Right lower lobe atelectasis, again the same principle will be applied like this. The triangular opacity in the right lower hemithorax. This is, look, the upward movement of the right nose of the diaphragm. It is indirect sign, and the fissure here, oblique fissure, will go down. So the hyperexpanded, and actually this is the haziness which I want to told you. It is very clear, and there is border is obscured. Selert sign. Left upper lobe atelectasis, again the same thing. There is a triangular type of opacity seen here on the upper side, and you can see the fissure goes up. This fissure goes here, it should be here, but not here. Here is the fissure. This is the triangular opacity. This is the Selert sign. Trachea is actually in central, although it is very 5-degree displacement, very difficult to diagnose. And upper lobe, it is in the patient with the incomplete major fissure. Major fissure is incomplete here, and it is the displacement which is seen from here to here. So this part is gone actually. So the trachea should shift in this position. The left lower atelectasis is concerning. Here you find that the badge-shaped opacity behind the cardiac salute, this one. And here you see there should be difference between the 2.5 centimeter between the right hemidiaphragm and the left hemidiaphragm. But is hardly 1 centimeter difference. And there is a triangular shape opacity here, wedge shape opacities. The border is formed by the major fissure. Although it is difficult to detect the major fissure here, it should be here. And the upper lobe is hyperextended. It is indirect sign. Hypertranslucency is there because of the collapse of the left lower lobe. Complete atelectasis, total collapse of the lung. It is what is maybe called as this is the opaque hemithorax. It is a differential diagnosis of the opaque hemithorax. One is this, one is the lobar pneumonia, third will be fibrotic lung, pleural effusion massive. These are the most common etiology of the opacity of the right hemithorax, total opacity. Direct signs are there, indirect signs are there. There is no diaphragm, there is Selert sign. Absolutely, it is involved, the whole part. So this is a difficult one, although only you can remember is the displacement of the fissure if you see, or there is a hypertranslucency above and down the hypertranslucency, there is a haziness at one area. With the indirect signs of the Selert sign or indirect sign is the tracheal shifting toward the same side. So this is the end of our sessions, clinical chest radiology, and I hope that you have enjoyed it. Probably, I don't know about it because it is not an interactive session. I will later on will try to complete it in the fashion that I will report these X-rays, a case presentation, so you can understand how to write it down the findings and what is the influence and how will you going to further investigate, etc. I hope you good luck in your life. Rabbi جعلني مقيم الصلاة ومن ذريتي ربنا وتقبل دعاء ربنا اغفر لي ولوالدي وللمؤمنين يوم يقوم الحساب ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار سبحان ربك رب العزة عما يصفون والسلام على المرسلين والحمد لله رب العالمين. Assalamu alaikum wa rahmatullahi wa barakatuhu. I thank you for listening. Please try to revise clinical radiology chest in session wise. Then try to report the X-ray chest randomly. Well, I will report first and then you will report. Assalamu alaikum wa rahmatullahi wa barakatuh.